Hi, welcome to part 3 of our case presentation and lecture series on acute headache emergencies when we attempt to save the brain. Just to review from our last 2 parts of the case, we have a 67-year-old male with a history of hypertension and diabetes that presents with acute onset worst headache of life, associated with severe hypertension, photophobia, confusion, left-sided weakness, and neck stiffness. We've so far started the patient on oxygen, started an IV, and he's currently on a cardiac monitor. We have treated the patient's pain and nausea and initiated some blood pressure control medications, and the blood pressures are now at 185/100, which was our goal. And so far, things seem to be stabilized for the moment. To review, the patient does have, on the CT scan, intracranial hemorrhage, blood in the brain, which is also known as a hemorrhagic stroke. Now, hemorrhagic strokes account for about 20% of all strokes, and half of those are from what we call subarachnoid hemorrhages. And what that means is that there's bleeding next to the brain and in the brain that is directly related to what we call Berry aneurysms. There's multiple blood vessels in the brain and arteries in the brain, and a part of the artery itself will become weakened and ballooned, and as that area becomes weaker, it can actually tear, leak, rupture, and cause the stroke. So half of all hemorrhagic strokes are from Berry aneurysms. These thin-walled, ballooned parts of the arteries are very delicate and very easy to tear and bleed. So in reviewing, looking at the previous anatomical slice of the CT scan, you can see the center part of this, it's called the circle of Willis, okay, which was essentially highlighted in subarachnoid blood on the CT scan. And what you can see is that there's many junctions between many different arteries in the brain. And all it takes is a subtle abnormality in one part with the pressures that the patient has experienced, elevated blood pressure, to lead to a small tear, rupture, and eventually bleed with devastating consequences. Again, this balloon can then rupture, causing hemorrhagic stroke. Now, the bleed can be quite small, a small little tear that then clots off. We call that a sentinel bleed. A patient can have severe headache, but there's not enough blood, pressure, or damage to cause severe injury to the brain. We call that a sentinel bleed because the next bleed could be the big one. If it ruptured, we call it a hemorrhagic stroke. So in reviewing the emergency medicine approach, we now have a diagnosis of subarachnoid hemorrhage. We need to make sure we reevaluate and monitor the patient and start acting on this new knowledge. And already we've started to do that blood pressure control. So again, just to review, anyone with severe headache should be treated for their pain and for their symptoms. So we're treating pain and nausea, we're controlling blood pressure. Now that we know that there's intracranial blood, our blood pressure goals are actually a little bit lower. American Stroke Association, or stroke guidelines for hemorrhagic stroke does meet a goal of systolic blood pressure of 160 millimeters of mercury. And again, we can use blood pressure control medications, including labetalol, esmolol, and nicardipine, to reach those goals. That lowered blood pressure is somewhat protective against further bleeding and rupture, although lowering it too much can reduce the perfusion, the blood flow to the rest of the brain, and can also cause damage. So a good target is sort of a mid-range goal of hypertension, which is a goal of systolic blood pressure of 160 millimeters of mercury. These patients have blood in their brain. Brain is actively being damaged or injured or irritated, so close monitoring of the airway and vital signs are important. And again, this patient had normal labs, but if there was any other concerns on the laboratory workup, such as abnormal coagulation factors, abnormal electrolytes, anemia, a lot of these should be, or abnormalities in calcium and glucose. All of these should be treated so as to minimize their effect in the context of injury to the brain from the blood, next to the brain from the blood vessel. So you have this diagnosis. We're starting to act to get the patient with definitive treatment. So we're going to call our neurosurgeon. Neurosurgeons or interventional radiologists with neurologic training are the only ones who can intervene on these particular cases. We need to medically manage and prevent further damage and prevent further treatment, but they're the only ones that can actively, definitively treat these. So we can either call them for admission to the hospital, or we need to arrange for transfer to another higher level of care institution that has neurosurgery available, because again, if anything goes worse, or to address this particular problem, it is a surgical process. As you're on the phone, you're called by the nurse to reassess the patient. The patient apparently has become sleepy. He's in there with his family. He's become difficult to arouse. The nurses gone and evaluated the patient and confirms this. And we're getting concerned that something may be declining in the patient's neurologic status. And is this patient sick? Of course, the patient is now even sicker. So we're going to reassess our ABCs at this point. General, patient is noticeably less alert. Now he's having incomprehensible sound. He is no longer following commands. Airways appears to be intact, but he's starting to have periods of what we call snoring or snoring respirations, where the airway appears to be becoming partially occluded. Breathing is now rapid, although the breath sounds are now clear. And circulation, you still have nice, strong radial pulses. Again, some of these are starting to get to be more dangerous and concern about airway at this point. So we will, at this point, repeat the patient's GCS. Patient now no longer opening his eyes spontaneously, now only opens it when you provide some painful, noxious stimulus. Now only incomprehensible sounds. And he's only withdrawing to pain in a general manner at this point. So as you can see at this point, it's eyes 2, verbal 2, motor 4. That's a total of 8. And we have saying in emergency medicine, if it's GCS of 8, it's time to intubate. So if you have a GCS of 8 or less, the airway is no longer considered protected. The brain is no longer functioning in an adequate manner to protect the airway, so we need to start intervening. So we need to intervene based on this new information. Plan is now to intubate and sedate the patient, carefully monitor repeat blood pressure, titrate medications to the effect, and we now have a solid blood pressure of 160 over 80, and the heart rate's now 62. Patient appears to be stable on a ventilator at this point. You reassess with the neurosurgeon about what happened and the patient's decline. The neurosurgeon will admit the patient to the ICU for monitoring, with a plan to take the patient to surgery for definitive intervention. Now, aneurysm repair for subarachnoid hemorrhage is the only effective treatment that's been proven to prevent rupture and further brain damage, and should be performed within 24 to 72 hours when possible. And the good news is that, at least with bleeding in the brain and blood vessels that are abnormal, a good third of these patients will have good recovery after treatment. All depends on the patient's pre-morbid level of health, meaning how healthy the patient was before the bleed had. Some of the vital signs, neurologic status during and after the rupture. And so the patient at this point will go to urgent care and will likely have a good chance of at least a reasonable outcome at this point. So the plan is disposition of the patient to admission and intervention. So in summary, I'll reiterate it one more time. There's a multitude of possible causes for headache, extremely common presentation. And sometimes it does feel difficult identifying those few cases of dangerous headache in the ocean of multiple normal headache complaints. But if you are wrong and you miss a dangerous headache complaint, it's potentially can cause death and severe neurologic permanent disability, so you have to be quite aware what's going on. Please, consider dangerous causes of headache if there are red flags in the history and physical. Diagnostic testing, of course, can help to narrow the differential and identify the cause of the severe headache. And especially with these high-risk patients, especially with neurologic disease, neurologic processes, they are unstable, need high level of monitoring, and you need to be available and aware to monitor, stabilize, control their airway if needed, because they have a potential to decline quite rapidly. Monitor and stabilize if needed. So that will conclude the presentation of acute headache emergencies, going from the beginning of a case of subarachnoid to the end. And thank you very much for your time.